So when we think about secondary traumatic stress, this is the emotional, physical, and cognitive reactions to indirect exposure to a trauma. So you're hearing, somebody else's experiences. It's a natural stress response when we're listening to trauma experienced by others. And secondary traumatic stress can have some overlapping symptoms with PTSD, intrusive images, memories, thinking a lot about that client and the story that they told after session, after you're home, maybe the next day, the next week. This can occur after one exposure. There could be a particular experience that you hear about that you are exposed to that really has a significant impact, and or it can be cumulative again, multiple exposures over time that just kind of grinding down your coping and your boundary between work and its personal impacts. This secondary traumatic stress is high among mental health providers. And in the literature, sometimes it can be used interchangeably with vicarious trauma, compassion fatigue, but there really is secondary traumatic stress is really emphasizing that impact on the nervous system and the ways in which those traumatic stress reactions are being kind of elicited within you through this exposure. And so thinking about things like the fight or flight response and how we can be at increased risk for this. The second concept is vicarious trauma. This is a change in a clinician's sense of self and the worldview. Vicarious trauma is the effect of prolonged indirect exposure, and it has an impact on somebody's beliefs about themselves, others, and the world, right? This is when we've been kind of doing the work, we've been seeing all of these things and really kind of getting to the point, either temporarily or hopefully not permanently, but like the world is just a bad place. No one can be trusted. The things that I've heard people be exposed to, it's just, this is a bad place to be. This is something that develops over a longer period of time and is more persistent than secondary traumatic stress, which might peak and then come down naturally or with the supportive coping strategies. Vicarious trauma is a little bit of a deeper experience, an existential philosophical change in how we're viewing ourselves in the world. And that it can also be it's like a secondary outcome of secondary traumatic stress symptoms. It's like we start there. If those aren't resolved, it can kind of build into and be baked into our understanding of ourselves, the world, and other people, which makes sense when we're thinking about how we approach PTSD treatment and that similar process. If somebody's exposed to something, they have the natural emotions that arise because of that. And then something blocks that natural recovery process. And those symptoms, those experiences, those beliefs start to become more ingrained into a deeper worldview. Compassion fatigue is empathy-based stress that's impacting our emotional engagement. And so this can have both physical and signs of both physical and mental exhaustion, right? Like that we're just hard to get out of bed, hard to be focused in session, kind of thinking about making comparisons about people's problems. And it can really reduce a person's ability and desire to engage empathetically with others, especially when discussing emotionally charged material. It's like you're so full up and maybe even overstimulated, overwhelmed, that it's like there's just no room left to take on anybody else's experience. And as a result, it can impact the therapeutic relationship and your ability to be present and deliver appropriate services. It can be an acute response, but again, this is something that's usually developing over time and having a slow impact on us. And it differs from some of the other things that we've discussed in terms of secondary traumatic stress and vicarious trauma, in that it has a little bit more of an interpersonal focus. Like it's our ability to be compassionate with other people. Burnout is an organizational issue with individual symptoms. So oftentimes I think in the literature and in common conversation, we talk a lot about burnout, and maybe sometimes we're actually talking about some of these other concepts that we've talked about. The thing that's really important about burnout is that it's a response to prolonged occupational exposure to challenging situations without sufficient organizational support. So this is like when an organization is telling you like, oh, make sure to take care of yourself, but also I'm going to need you to take on these 5 new intakes, right? There's these organizational pressures that make it really hard to do the work that you want or need to do to take care of yourself and to take care of your clients. And so while burnout can occur in any work environment, working with trauma exposed clients without adequate support contributes to that increased risk of burnout. When you feel like you're doing it all on your own, you don't have any other supports, it's up to you to meet all of the needs of all of your complex caseload, that increases your risk for burnout. Mental health professionals have one of the highest levels of burnout, and that rate only increases in the public sector. And so this, comes to mind in thinking about group practice, private practice, and the ways that you may have intrinsically or implicitly kind of maybe supported yourself or protected yourself from burnout, and being able to have a little bit more protections built in for yourself. Not always, though. We can obviously still experience burnout in any setting. But when there's that extra level of sense of helplessness or powerlessness within a system, that increases that risk for burnout. When we think about the risks for these experiences, in terms of individual risk, we can see things as like a history of your own trauma, right? And the ways in which that might be cued or reminders might come up in the context of exposures to other people's experiences. We see that the risks are higher for when people are first entering the field and they have a less experience. So they just don't quite have their toolkit developed yet. They're still trying to navigate who they are as a professional, how they want to relate to their clients. And we all know that it tends to be the newer people that get the harder cases, right? Inadequate coping strategies, right? We don't have a toolbox yet to really cope with the content that's coming up in our work. Inappropriate boundaries. And this is really hard, again, as people who are coming to this work motivated to help others, that inability to shut off, to take things home, to overexert yourself to the benefit of someone else, to the point of harming yourself, increases your risk for these negative outcomes. Negative client feedback or therapy interfering behaviors, hearing you're not helping me, I want to do this, not showing up to sessions, all of the things that occur that can interfere with progress in therapy can increase risk for burnout. All of these are compounded and existing within these systemic risks. High caseloads with high percentage of trauma cases, lack of resources for treatment or referral, insufficient support or supervision, not having a place to debrief, to check in, like, does this sound right? Did I do the right thing? Anything else I should be thinking of? And also chronic tedium in the workplace can contribute to feelings of hopelessness, feeling like you're doing the same thing day in, day out, not seeing much change, not having a experience of a dynamic or vibrant workplace in and of itself can increase risk. I've been talking a lot about the potential negative outcomes of trauma exposure, both for clients and us as professionals, but it's also important that we make a note on resilience. Our ability to meet challenges, to do well and survive despite adversity. And so as clinicians, we face really difficult challenges every day, and yet we show up and we make a difference in people's lives and we do good work. And our clients benefit. They are able to heal. They're able to live a meaningful and valuable life, align with their values and goals. And so even when people are exposed to trauma at these different levels, we still have an opportunity to live a life that we want to live. And that's what brings us to this work and why trauma-informed care is so important, is that we're creating the possibility of a different narrative, of a different outcome. A few more concepts related to that is thinking about post-traumatic growth and compassion satisfaction. Exposure to trauma does not always lead to these things that I've discussed, to the development of lasting traumatic stress. Post-traumatic growth, both for us as professionals and for our clients, is that when somebody's struggling with trauma, they can have a positive transformation, including increased resiliency, improved relationships, optimism. They can see existential or spiritual changes, It can be an opportunity for us to really take stock about what's happening in our lives, how we want to move forward, what's important to us, people that show up in our lives in a way that we didn't expect before the event. So it can really deepen our relationships, demonstrate to ourselves our resilience, and contribute to our growth ultimately. Compassion, satisfaction, the pleasure and satisfaction of getting to help others. Our work can have really low lows, but it can also have amazing high highs in terms of that when we can see somebody really benefiting from the work that we do. And this is a protective factor, and it's an antidote for compassion fatigue and burnout, is seeing those successes, seeing those changes that people make after the work that we do with them.